Thank you all so much for being here. I really appreciate your time. I've gotten to work with some of you for years. Others of you I've only gotten to know in the last couple of years. So I'm just really excited about this specific group. I think we're going to have a lot of fun talking about all of this today. And first, before we dive in, I would just like us to introduce ourselves. So I'm Megan Golden. I'm the Director of Community Health and the Director of our Survivor Recovery Center for the Department of Family and Community Medicine. And just a spoiler alert, all of us work for the Department of Family and Community Medicine at Southern Illinois University School of Medicine. So I'll just go by who's next to me. Hannah?
My name is Hannah Jacobs. I am a licensed clinical social worker. I work with our comprehensive care clinic here in family medicine, and then I also work as a generalist behavioral health provider. And then I supervise some of the community health workers that we have located here in Springfield, Illinois.
Dr. Maroka?
Hi, I'm Nicole Maroka. I have been with family medicine at SIU for over 16 years now. I concentrate most of my time with resident training. We have 30 family medicine residents that go through our clinic every day, and we work with them throughout their training for 3 years. I work in the comprehensive care clinic in our office, which is a specialty clinic designed to really help those with some of the most complex social and medical disorders that we help them work through.
Perfect, thank you. Bonnie?
Hi, I'm Bonnie Landwehr. I'm a licensed clinical social worker here at SIU, and I also supervise the behavioral health and integrated care team.
And Dr. Bhandari? Oh, Dr. Bhandari, you're muted.
Hi, everyone. I'm Priyanka Bhandari. I'm a family physician and a faculty in the Department of Family and Community Medicine. I also work with residents, just like Dr. Maroka. And I also, we have recently started our gender equity clinic, which is our specialty clinic for taking care of a sexual ethnic minority.
Perfect, thank you. And Calvin?
My name is Calvin Miller. I am the recovery support specialist for the medication assisted recovery team. And I am a certified alcohol and drug counselor, a certified, oh boy, let me make sure I get them all right, medication assisted treatment therapist, and what's the last one? Oh, the CRSS, certified recovery support specialist. And I get to work with those struggling with the disease of addiction, specifically to opioids.
Thank you so much. And last but not least, Becky.
Hi, I'm Becky Howard, and I'm a pediatric nurse practitioner. And I get to work at Family Medicine because I have a clinic called the Kids Health Harbor, which is a comprehensive clinic dedicated to children in foster care and other similar difficult situations. And we are very fortunate to be able to provide pediatric primary care as well as integrated mental health care, and work a lot with the casework agencies to make sure the kids are getting all of their healthcare needs met.
Awesome. Thank you so much, Becky. So we've got comprehensive care clinic, equity clinic, medication assisted recovery clinic, and Kids Health Harbor. So that's a lot of words and a lot of different experiences for our patients. I'll just let you all kind of voluntarily share. Tell us a little bit about your clinic, your specialty clinic, and maybe walk us through a typical clinic. You know, who's there, what services are provided, what does it look like for the patient?
I've got to get off of here at 4:30.
You go first, Calvin.
I'm taking 2 days vacation and heading south. So
you earned it. You deserve it.
Love y'all, but it's my time at 4:30.
Absolutely. Yeah. What can you tell us about Matt Clinic?
I really, one of the themes here in this clinic is you can't make this stuff up. And there is just always so much going on with those struggling with the disease of addiction, from, you know, in the stages of change from someone in pre-contemplation to someone in the maintenance stage, wanting to change. And there's just so much so many different stories, so many different ways, so many different things. It's really challenging, yet it is very rewarding when you see someone flourish and grab hold of recovery. We just had someone call who has, I think it's 2 years, and he said that he is living a productive life, family, got people he loves around him, has a job, and has just a great life. And he can remember coming in here. He remembers digging around in the dirt for cigarette butts, having nothing, no food, no nothing, and just had no hope. And now he is a productive member of society, and that's just one of those beautiful things. And although it is a low percentage, there is a percentage, and when they do grab hold of it, it's a good one. I'm also in long-term recovery myself, so I get to be encouraged with that, and also just continue to get to fight and fight and be someone who is there to help those who actually want to help, because somebody was there to help me. So we we've got 4 doctors currently. It was 2. We've doubled up, and we're going to be expanding and having more people come aboard. And we've got Brittany Presswood, who is she's the one, the cog that keeps all the wheels turning and keeps the appointments going. And it looks, just a day in here looks like Dr. Dunkley coming in with her beautiful accent and her goofy way of just doing things. And she is, we laugh, but yet we know that this is very serious, and we get a chance to help people, and we get a chance to see how Suboxone can help, but can also be a hindrance. But there's also, we're about to add some medications once we figure out the refrigeration challenge that we've got going on. But medication assisted recovery is an absolute blessing in the lives of those who that need it. And it's just more and more evident every day here. Also, we do groups. I personally do a group every day, Monday through Friday, and get to do it just varies from relapse prevention to coping skills to communication skills, relationships, just anything that falls underneath that recovery support, and having having the support necessary, but also knowing that the process is there for an internal change. That intrinsic motivation for change is very important as well. So I hope that explains it well.
Definitely. That was a great overview. And I've heard about Calvin before he even worked at SIU. When he was working at a treatment center, I would have patients come in and talk about how much he'd helped them. So I know we're so grateful to have you, Calvin, here at SIU. Is there anything else you want to say about Matt Clinic or your role or anything?
Just, it's good to get to know more people, because we get so busy here that don't get to reach out. And I mean, Bonnie harasses me every now and again, and Megan, you harass me, but it's good to get to know more people in the building, faces that I see, and actually get to know you. So excited about that.
Absolutely. Well, thanks so much for being here, and enjoy your vacation.
Thank you.
Who'd like to go next?
I'll tell you about the comprehensive care clinic. I think it was about 6 or 7 years ago, we decided that we wanted to sort of change it up. We realized there was this group of individuals that were having trouble sort of navigating our own system. And we thought our system was pretty good with our federally qualified health center. But of course, there was this group, that has trouble understanding or navigating, the scheduling system, just the idea of fitting into a regular clinic where you see, your provider, and then you get referred off to somewhere else. And then also the system of primary care and what that's about, and really engaging with that rather than engaging with emergency services on a regular basis. So I went to administration, and with the help of some people who were encouraging me to go for this. And it was not my idea. But I went to administration and I said, hey, these people want me to do this. Can we just block my schedule, open it up for these patients that need a little extra hand holding? And I'm not going to do it alone. We're going to have social work there and pharmacy to help us out and the community health workers. And so we created this, you know, sort of in a beginning, this open access to these patients. And really our community health workers were the backbone of getting that started. And we just went with it. You know, when a patient, you know, was given an appointment at 9 a.m. and they showed up at 11, we saw them. You know, when we got a call from the emergency room and they said that, hey, this patient keeps coming in and you guys need to do something better, we saw them. We took them in. And so the panel grew and grew and grew. When the hospital team had a patient that kept getting admitted for whatever reason, we took them on. It has not been able to continue exactly like that, but we learned, you know, we learned as we went, you know, with what we had to do with these patients in particular. So that was the birth of the comprehensive care clinic. We still see patients in groups, meaning the patients alone, but I have a social worker with me, Hannah, as you see, and then our pharmacist, clinical pharmacist, is there when she's available for that. And we have our community health worker, again, has been the backbone to a lot of the work we do. So I hope I'm not forgetting anybody. So Hannah, chime in if I am.
No, I think the only other person that we do have on our integrated care team is a legal professional. We have an attorney that we work with through Lincoln Land Legal Aid, and they're able to assist our patients with
Awesome.
a lot of their complex legal needs.
Yeah, that's a biggie.
Housing issues to, you know, criminal, getting their criminal history expunged. So that's a really amazing asset that we have.
Can I get in on that?
Yes, it's open to all of our patients. So you just need to put a referral in. But in the
There's
beginning,
Reno.
the beginning of
Bonnie
our
will tell you
morning,
about Reno.
in the beginning of the morning, we do start with a huddle, and I that's not unique to healthcare in general, but it was kind of unique to us. We hadn't really been doing that. So this morning huddle, we go through the list and we say, okay, who's on deck today, and how are we helping them? And it's different than how I went through school. I went through school like, okay, we're treating their diabetes and their blood pressure and whatnot, and their mental health too. But now it's like, it's really is, and I did not come up with this phrase, it's truly the intersection of social work and medicine, and really seeing like all of the aspects of their health. And it's so much more than just treating their medical issues.
Just kind of piggybacking off of what Dr. Morocco was saying, because I also work in comprehensive care clinic with her. The community health workers are definitely the backbone of our clinic. They basically serve to address all of their needs that can't be met inside of our 4 clinic walls. And so they're definitely an integral part of our team. And we're super excited that COVID kind of put a halt to a lot of those services. And we're super excited to be reintegrating them back into the clinic and having them work with a variety of our different specialty clinics to really make sure that we're kind of understanding where the patient's coming from and what kind of barriers still exist that we might be able to address, when they're not able to come to appointments or engage with the healthcare system.
I thought that was so perfect. It was a great overview. And I like that you even kind of talked early about your program, because a lot of the other specialty clinics came after comprehensive care clinics. So Dr. Morocco, you've been a real trailblazer in helping administration see the need for kind of transforming the way we do medicine for some of our populations. So I think that's a really important point to make. Others, do we want to hear about Kids Health Harbor or Gender Equity Clinic next?
I can go. It's Becky. So the Kids Health Harbor has been around for 3 years now, and kind of explained, it's a clinic mostly dedicated to kids in foster care. So the kids that we see are from newborn up to 21, because kids can stay in foster care until they're 21. And the services that we focus on, like I said, are primary care, but then we also are very fortunate to have integrated mental health care thanks to Bonnie's team of counselors, and then Dr. Dobbins, our psychiatrist that works here at Family Medicine. The other things that we kind of do are a lot of extra communication. So we communicate, of course, with the foster family and the biological families if they're involved, and then the casework teams. And we do that by paper communication and a lot of verbal communication. So once a month, I meet with each agency to kind of staff through all of the patients that we share to make sure that nobody's getting left behind on any services that they need, especially if kids are moving from one home to another. They can easily get kind of lost. What we really strive for in our clinic is to be a medical home and an area of continuity for the kids so that they don't have to start over. And that's one of my favorite parts, because each time I see the kiddo, even if they're with a new foster family who doesn't know anything about them, I already know them. And so we don't have to start over with square one and figuring out diagnoses and medications and that kind of thing, and we don't lose as much ground. Then the most amazing thing about my clinic is just meeting the kids. I think in all the people I've met in the world, they're the strongest and most amazing people in any walk of life. And they do great. I think also, I guess to talk about getting started, this kind of started in a very fortunate way that Dr. Brenham is who I met with originally, and now she and I work on child abuse cases together. But she saw the need and allowed me to be adopted into family medicine. And then luckily everybody else thought that it might work out additionally. So that's how we got going, and we're growing and hopefully in the future expanding even more services.
Thank you so much. I was really excited to hear about Kids Help Harbor. Bonnie and I both started off in child welfare in our careers, so we know how fragmented that system can be. So the fact that this is available is huge, especially considering the trauma a lot of those kids have been through.
Yes, for sure.
There's a really cool poem that talks about tending to the tender things, and that just, it makes me think of Becky whenever I hear that, because that's absolutely what she's doing.
Oh, thanks, Bonnie.
You're welcome.
If you could send that to me, we can post that with our presentation.
Sure, I love that.
Great. Dr. Bhandari, did you want to talk to us about the Gender Equity Clinic, which is our newest specialty clinic? It just opened recently.
Absolutely. So like Megan said, our Gender Equity Clinic started very recently. I think it was August of last year that we formally started the clinic. This clinic is a brainchild of Dr. Brenham. She had been trying to start this clinic for a while, but obviously because pandemic hit, everything got pushed back. Once things started stabilizing in 21, we started, of thinking back to start the clinic finally. And we have been running this clinic successfully now for almost 8 months. What we basically do in the clinic is it's clinic for our sexual minority group, our transgender group, our LGBT. But we are not just limited to that. It's a clinic for everybody. It's a clinic for a cisgender person as well. We have, over time, we felt there was a lot of unmet need for specifically our transgender population, LGBT population, to find providers who were willing to work with them during the transition due to various reasons. Most of the patients in Southern Illinois or Central Illinois were going to big places like St. Louis, Chicago, and there was a dearth of providers or facilities that they could access, within Southern Illinois. So with that background in mind, we started it. But like I said, it's not limited to that specific population. Anybody is welcome to come and, be seen in the clinic. What we do is when we evaluate the patient who's coming to the clinic with concerns about transition, we do a very comprehensive history. We see if the patient is actually, ready for the transition, or is it, just a floating thought that they have? Is it like the gender fluidity thing, or is they actually, made up their mind that they're going to change what all entails in that process? Are they ready for that? A lot of that involves history taking, talking to them, and that also involves evaluation with our counselors, our integrated healthcare providers. We have Kelly, who is our integrated healthcare provider who works with her, and she's awesome. We also have the support from Dr. Dobbins, who is our psychiatrist. In cases where we are not sure, about the diagnosis. And also we need them because a lot of this population also has underdiagnosed, untreated mental health concerns. So it's a very comprehensive clinic where we feel, okay, we will start the process of the transition once we are sure that the patient is ready for it. But at the same time, we also want their mental health to be taken care of. So we have the counselors talk to them, and as and when needed, we have them refer to Dr. Dobbins or any other psychiatrist, if needed. Other than that, we do also take care of their preventive health stuff. We also make sure that if the patient does not have primary health care, which a lot of them do not actually, we try to establish them with our family medicine primary care clinic. So a lot of patients actually who started coming to our clinic have also established primary care with us. We do that. Then we provide them information about the hormone therapy, which could be the masculinizing or feminizing hormone therapy. We also provide referral services to our surgeons, for the top surgery, bottom surgery. We have a few in town, and then we can also refer them to the bigger centers outside Springfield. We have also been trying to provide them more information about other services like sperm banks or over banks, and how to access them, legal help in terms of their legal change of their names and all. So we slowly, every day we are trying to expand the services that we can provide to them. So it's one step at a time. But I would tell you, we have had enormous success with our clinic, and it's been very overwhelming to see, that there was so much that needed to be done. And, I'm happy that we went forward with this step.
That's incredible. That's so much that you're doing in such a short time, having just opened recently. I've had at least 2 clients that I work with go to Gender Equity Clinic and start hormone replacement therapy, and they're so happy. They feel so well cared for. And it means a lot to them that they can get that service in the same building that they already get other things. So they already trust us. Family medicine is a home for them. And the fact that they don't have to go somewhere else for this is wonderful. So thank you so much. I wanted to kind of...
Can I say something real quick, Megan, too?
Yeah, please.
It's also been very helpful for a lot of my kids. Some of my kids are in foster care because they identify differently and their family does not accept them. And it ends, unfortunately, very traumatically. So having that extra support here also supports our clinic as a Kids Health Harbor, too. So thank you.
I just want to say it's not only helping patients, but it's helping the profession. I feel like even just adding the Gender Equity Clinic to our system here in Springfield has really taught the rest of us about understanding and learning more about that care. And because it's not something that It's not something that was ever taught to me in med school. And I got to tell you that this type of change you're seeing is happening now in med schools. You know, it's happening here, but now, I mean, it's adding to the curriculums now. So you are definitely setting an example for the rest of us to learn more about it.
I think this is a great setup for kind of moving to talking a little more about trauma. I know that I've only worked personally with Comprehensive Care Clinic in the past before Hannah, but I've heard a lot about all of these clinics from patients that I treat for therapy that are in them. And one theme I think that's across all of them is that these clinics attract people who have a lot of histories of trauma, especially abuse and violence, and victimization and things like that. So I was hoping that Hannah and Bonnie could talk to us a little bit about how both the integrated care team, which is made up of licensed therapists, and then our community health worker program, how do those two roles kind of help treat that trauma and address it? You know, how do they practice trauma-informed care within these specialty clinics, and why are those two roles so important in these kinds of clinical innovations working over time?
Absolutely. And with integrated care, we have the pleasure of getting to work with all of the clinics. We get to see everything, be part of everything that we can. Every member of my team has their own kind of niche area that is their favorite, but baseline, we work with anyone that needs us. And that could be anything. Not only do we have a strong focus on trauma here, but we're also looking at kind of that in between as well. Those folks that are functioning very well, regardless of their trauma, regardless of their symptoms, that sometimes get forgotten. So we're able to, through our involvement in regular continuity clinic, piece those out and find those patients. Oftentimes when I get called into clinic to see a patient, they'll tell me, this is the first time someone's ever asked me, or I didn't plan to come here for this. I was coming from a pap smear. I did not plan to tell someone about this abuse that happened to me in the past, or how my panic attacks are taking over and I might lose my job. So just that, it's just amazing to know that we're training providers to have trauma, to work within a trauma-informed lens. And then they're more open to mental health participation with that too, and see the benefits. It's no longer the medical model anymore, and more people are jumping on board, and we've been able to be at SIU the example for that.
Yeah, I completely agree with what Bonnie said. I had a patient the other day that came in and they presented with all of these physical symptoms when in reality it was a lot of unaddressed trauma that was going on with them. And so just kind of being able to dig a little deeper was, you know, super helpful for that patient to feel validated. And I know that our providers don't always have the time to kind of peel away those layers and figure out what the underlying issue is. And so we're really fortunate that we're able to work in conjunction with them to make sure that we're figuring out what the kind of root issue is there. And then our community health workers really just kind of go even further than that. So any patients, I think in our comprehensive care clinic specifically, the best way that we're doing trauma-informed care is to meet the patient where they're at and allow them to come to our clinic even if they're 2 hours late, and figure out, you know, calling them if they no-show and figuring out what's going on. You know, are they sick? Were they having a lot of anxiety? Were, you know, their car broke down? Whatever that barrier is, but just calling and following up with them to show that we do care whether or not they come to their appointments. And those are the kind of like little details that sometimes get overlooked because healthcare is a fast-paced environment and we're all super busy. And so the community health worker is kind of able to go that extra mile to really kind of get to know the patient, you know, go see what their home environment is like and figure out what are those additional barriers that are going on there. Because trauma doesn't always present as trauma, you know, like there's usually a very different presentation, and we don't always pick up on that. Even as mental health providers, sometimes we don't pick up on that. So I always like to think about it. I don't remember who told me this. I think it was Megan, but it's just like, always assume that every patient that you see has trauma. And I think once you start looking at patients in that way, you're just able to be a lot more, you're able to validate their feelings and their experience a lot more, rather than assuming that they haven't gone through those things.
the coolest thing about having Hannah, I mean, just here in general, but she has that awesome lens to where she can see, okay, yes, their depression's getting worse, but is it because of a housing issue? She just told me a patient the other day where it was a referral for depression. It had nothing, they were depressed because of that social determinant issue. It had nothing to do with their actual mood. It was just their general livelihood stability. So we have that extra outlook on patients with Hannah and with the community health team that we wouldn't have otherwise.
I couldn't have said that better myself. Yeah, Hannah is such an invaluable member of the team, and she's kind of the one person in this panel that has a dual perspective because she's worked as a community health worker for several years, and now she's a clinical therapist. So, yeah, Hannah, your leadership's been really important in developing all of this change, and especially our learners, our interns, and med students really respond a lot to Hannah's perspectives and stories. So speaking of perspectives and stories, nice segue to cases. I wondered if anyone, we've talked a lot abstractly about these clinics and why they're important. Sometimes it really takes a case to make something make sense. So thinking of kind of all kinds of people could be viewing this, from medical providers to people who are not in the medical profession at all. So do any of you have a story that you're willing to share about someone that has been in your clinic? And it doesn't have to be a success story. It can be a challenge story, you know, whatever you want. But I think cases really help bring things home. De-identified, of course, with all the major details changed.
I have someone right now that we've been working with, and I don't know where I'm going with this story, but you talk about like not presenting, you know, like the trauma doesn't present with actual trauma, you know, complaint, you know. So we have an older lady who is pretty alone in the world. And she comes in and we never know how the day's gonna go. She's either gonna be, you know, spitting fire at us, usually. And sometimes she's really, really nice and sweet. And, you know, I've heard about her apple pie. So I haven't ever been able to get any piece of it, but because she's usually pretty mad at me. But we recently had an interaction with her, and her psychiatrist reached out to me. And so long story short, I thought she was just going to be really mad at me and not want to talk to me, not the psychiatrist, but the patient. But the psychiatrist says, you know, you're the only one she trusts. And I was like, really? Because she usually just yells at me when she comes in. She usually just, you know, like, I'll just go home and die. You know, she'll say things like that. She has been fired from I don't know how many clinics in this area. But so I think and she's had a lot of trauma with I think losing her husband and you know, her previous health long ago when she was very young. So getting to the point, I think she doesn't know how to always show her affection. Her affection is spitting fire at me. And I think and I feel like many times when I see her, I don't do anything. I just listen and I take it. Maybe I'm just a dartboard for her. But she apparently really trusts me, and we're there for her, and we will continue to see her despite her social communication flaws. Do you have any insight for me?
That's a beautiful story. I love that story because the patients that are not innately likable are easy to deal with, tend to get, you know, research shows us that, tend to get worse medical care. And you might be the only doctor that's ever seen her over a year, you know, who knows? So I thought that's super good story to illustrate trauma-informed medical care. Other responses or other stories?
I'd like to brag a little bit on Becky with her impact on kids. So coming from child welfare field for a long time, and having been the person that when kids came into care, I sat in an ER for 12 hours. I heard my alarm for the next day go off and panic cried because I still have these kids that I still need to place. And suddenly with Kids Help Harbor, when kids come into care, they can come here for their initial visit rather than sitting in an ER waiting room with God knows what, especially during COVID, when you may not have even been able to do that. Get a provider who's trained, not just some random like ER traveling provider who's trained in dealing with kids of trauma, in a clinic full of trauma-informed people. So not only does that assist a transition that's ugly regardless, but also when I talk to the workers that have kids that come here and just the lack of stress that they have in dealing with Becky, rather than calling around trying to get records, you figure out what doctor's office they went to. A case gets transferred from Chicago down to the central region. Where are their records at? What's going on? And suddenly we have this central place. So even though it's not, I don't have a specific story for it, it's just the trauma she's taking away from patients and the workers and the foster families just by one medical visit with her and someone that cares in that moment, regardless of the circumstance.
I still think that's a good story because that's a caseworker story. Having been a caseworker for 2 years for children in care before coming here, I can relate to that. And we had nothing like this. So Bonnie, you're kind of highlighting that our work isn't just about our building. It hopefully is reaching other community agencies. My favorite thing to do is to brag about Dr. Maroka, and she's kind of the doctor for the drug court program, pretty much. You know, a lot of the patients that go through drug and mental health court end up with her as the physician. She's been to several trainings with me over there. And they all trust her and they all want their patients to see, they all want their clients, they call them clients, to see her. So I think a lot of the specialty clinics have reached outside of the building into the community. And I know I've talked with Dr. Jonna Cooley at Phoenix Center, and she is just so excited about Gender Equity Clinic as well.
Oh my gosh, yes. And I love to see that Dr. Bhandari is always, whenever I walk past her cubicle, she's always researching something. She's always reading something. She has an article to tell me about, or Kelly will tell me, oh, Dr. Bhandari and I discussed this new trend. It's not only is it a new clinic, but it wasn't just started and then we hoped for the best. Like there's just such constant continued education to make sure we're on the front line of this.
We try we try to keep updated with the latest out there. Yeah, but just touching on the topic of trauma, I don't have any particular one story to say as far as the Gender Equity Clinic is concerned, but I would say trauma is pervasive in this population. And every day that I work in that clinic, I have a better realization of the trauma. Sometimes it's overt, sometimes we have to dig it and take care of it. And but it's very sad and unfortunate that this population has gone through so much bias, so much trauma at every stage, whether it's school, college, work, home, like immediate family, and sometimes society has just completely abandoned them, so they are basically like alone, trying to find ways how to navigate life. It's an enormous trauma that they have gone through, not physically, maybe not physically, but a lot of emotional and mental trauma that they have all gone through. And that's why we have these great our counselors out there who can help us while we are taking care of the medical issues for the patient. They can help us be a great team, so we can take care of the trauma, we can take care of the mental health issues, primary care, all together at one place.
Yeah, doing it all at one place is kind of the crux of specialty clinics, because I know in comprehensive care clinic, there's 4 disciplines represented most days. That's 4 buildings, 4 intake processes, 4 fee structures, 4 opportunities for people to not get the service because of many different complex social issues they're having. So I think that's one of the key things, is that it brings everybody together, and it's wraparound care. So we have a few more minutes. I just wanted to invite any of you to share anything you wanted to say and didn't get to say, or any advice you have, because I know that people sometimes, when we present it on some of these clinics, they are excited about the possibility, but they're very overwhelmed by asking for change or trying something that hasn't been tried at their clinic. So any advice you have for any medical providers, social workers, healthcare individuals who might be seeing this talk?
This is Becky. Don't give up. It took me about 4 to 5 years to get it going. So don't give up. It'll happen.
Yeah, I think if the provider feels that there is a need for a particular specialty clinic in the area or in their field, I think, and they are genuinely interested in it and want to work with the administration, with the society to go ahead and have that set up, I think it might take a while, but over time it will happen.
I think what's important, not only, I guess the patient always comes first. You always think about the patient as the center, and we're providing patient care. But part of learning how to practice in this way and meeting people where they are really does take the stress off of you as a provider. And you think about, like, we have a whole, I don't know if epidemic is the word, of providers talk, burnout. You hear this term constantly. We have every medical institution in this country is trying to figure out how to help wellness, provider wellness, and define it and figure out if it needs to be yoga with goats or if it needs to be more vacation days or more therapists for everybody. Whatever them donuts on Fridays, whatever it may be is wellness. But for me, learning how to do trauma-informed care better, working with my team better, is wellness for me. And I think that has been rejuvenating in my career, and I think that it can help others.
We might actually end on time. I will just give advice to early career people that might be watching this that might not think they're prepared to help with a new clinic or a new project or a new group you hear about. I've done a lot of things I felt unprepared to do, and some of them I truly wasn't prepared. But you can learn a lot as you go, and if you align yourself with really smart, driven people, you can pick up a lot. So I would just advise, especially early career social workers, just get involved in new things, work with new populations. You never know what's going to really grab you and what you're really going to love.